conduction of system pacing, what are the things we need to consider? I will start to presenting a case, which is actually a quite interesting case. She will actually refer back to us for pacemaker erosion. He actually have some AV block and a DDD pacemaker implanted back to 1996. He actually have a lead dysfunction 4 years later, have another lead to be implanted, and actually had a device replacement in 2014. So you actually go to New Zealand somehow and actually get a pacemaker erosion. And I was asked, how come you get to New Zealand, get erosion? He said that we expose some raw lambs and also some cheese. So we'll talk about this later. So it's a bit tricky with this particular case. So it's, after that, and then she actually treated with a course of oral antibiotic, but the pacemaker erosion persists and subsequently developed some erosion. And all the blood culture seems to be negative, and then we do some prolonged culture. And then at that time, she was sent to us, and then when we did the echo, there's some thickening and calcified tricuspid leaflet because of the old lead, possible vegetation, and then she was treated with IV daptomycin and referred us to a lead extraction. So this is what I saw, the echo. You see that there's a big calcified thing here. I don't have a good feeling, so I say that maybe you should go back to New Zealand, find Dr. Lever, and then do the extraction. So I don't have a good feeling with this case, but we can know that this is actually a very tricky case and end up with quite messy. So this is actually the lead she actually had. You look at the access site, it's quite strange because she actually had 3 leads. So 2 of them actually through the subclavian vein, but 1 of them actually in the implant, they're doing through the inferior vena cava. So again, when we try to do the lead extraction, we need to think about the possible access sites or what is the indication for this access sites. I mean, especially when you have this IJ related lead, and then how can they actually implant. So you see that she actually had a 2 lead through the subclavian vein, and 1 somehow through the internal jugular, go from the neck and all the way down. So the indication is actually, in fact, after we do the extraction, it was quite a lot of bleeding after the site because there are 3 puncture sites. In fact, what will happen is actually after we do the whole lead extraction, this patient get hypotension, shock repeatedly, and then massive bleeding. So which is not usual when we do the usual lead extraction. But what I actually did is actually when we do a renogram, they actually leakage from multiple sites. So because of the 3 sites, we actually do the lead extraction through the at the end, we need to call the surgeon and need to do the pication to stop the bleeding from the subclavian vein. And then if you look at that, so obviously we go through the step for lead extraction. We start from putting the Steinac, and then so you actually have 3 lead. In fact, this is one of the lead actually impinging on the tricuspid valve, actually causing a lot of problem. But we start from putting a locking silet, 2 lead we actually completely lock, and then the 3rd one we are not able to do that. So you see that when the lead is completely locked, you see that there's a Y come out down here. And then the last one we cannot able to lock completely because there's a tidy band and all this old lead. And we start from doing this extraction. So this is the locking silet. So supposed to put into the lead, they expand and then try to grab the lead so that you can actually make the extraction much easier. In some of the situation, like when you're not able to do this, like for example, when you do this with the leadless luminous lead, like the 3830, then you may need to do a bulldog. So you need to extend the lead, extract the length so that you can actually pull that. And for these particular leadless, luminal leads, in terms of the bulldog, we actually need not to cut out the teeth, but also you can able to lock some of them. And then now there's some experience of using how we're able to extract some of the luminal leads with this kind of bulldog lead system. But I think the important thing, you don't need to damage the inner layer so that we don't damage the integrity, so that we retain the strength of the lead when you do the extraction. So in fact, this is another not the same case, the other case, we actually did this with this 3030X. So patient who actually have a TAFI, have complete heart block, and then we need to extract the lead because of infection and erosion, and we're using the blue dot, and then we can easily extract the lead. Surprisingly, with this luminous lead, is actually quite simple to extract. I mean, for my supplies, we don't need to using a locking, all these dissection tool. A lot of time you can just simple by traction you can do. In fact, if you look at some of the series recently published, and then you will look at most of the people can able to very easy extracting this luminal leads with simple traction. Small amount of patient you need additional tool. That is actually quite different from what we experience with the conventional lead. And again, if you look at this series, patients have infection. Most of them, they don't need to use any particular thing, and then most of the time you can actually reput it out very easy. So I think that may be one of the advantages with the conduction system pacing, because some of these lumen lead appear to be much easier to remove. However, obviously we don't have a long-term experience with that, and we still need to look at that. And then for my case, come back to that, after relocking, we usually start with a short dissection tool with this mechanical revolution tool to dissecting the initial segment, and for the 3 leads, and then we're able to clear up the initial layer. And then we're followed by a long mechanical dissection. As here, you can see that now I need to go back all the way, and you can see that able to extracting the lead. We'll start from 9 French from the above, and then I change to 11 French for the longer one, and successfully removing one of the, this is the newest one, so that's supposed to be the easier one, okay? I start from the easiest one. And then for the next one, it's actually much difficult because actually hung up into the tricuspid valve. There's a lot of vegetation and tissue. So eventually I cannot pull it out. You see that I stuck there with the 11 French sheath. I cannot pull. So what I did, I upsize to 13 French. And eventually all the thing come out from this particular, with the upsize of the dissection sheath. Okay. And then similarly, I'm using the same sheath, using a bigger one, also successfully removing that. Okay, but hopefully this will be the end of the story. But unfortunately, as I told you, he actually developed shock, and then so we actually need to ask a surgeon to go into picating the vein. But the problem here is, again, what Neva mentioned is actually after the extraction, a lot of time you see a damage in the tricuspid valve. So this patient actually, after that, she developed quite moderate degree of tricuspid regurgitation. But unfortunately, when we actually combat the blood culture, he actually had brucellosis. That's actually getting from the raw lamb. He actually got from New Zealand. So he actually contacted with brucellosis, in which we need a very prolonged antibiotic treatment. So she is now already on 6 months of antibiotic. The titer is still positive. So that's why we cannot fix the valve, because the surgeon don't want to touch her with that, and then she is relatively asymptomatic. But unfortunately, she actually still need a pacemaker. So eventually what we need to think about the option. So what we need to do after extraction, we go for leadless pacing, we will go for conduction system pacing, LV alone pacing, or even go for epicardial pacing. And obviously for this patient, the surgeon don't want to touch her, so I end up with having put in a leadless pacemaker for her. With the understanding that she's still titer positive, there may be a recurrent risk of infection in this particular patient, but there's not much option that we can do. And then we end up with putting a leadless pacemaker for this particular patient. But obviously for some other patient after lead extraction, if the heart function is not good, there are other potential solutions. This is another young patient, 24 years old, congenital heart block, actually developed some form of cardiomyopathy, right? Cannot move the. So if you look at that, he actually has some ventricular dysfunction. You see that dyskinesia with the pacing lead, and then also some moderate to degree of tricuspid regurgitation. And she sent to us because the lead failed, and then she need a pacemaker replacement. And we talked to this young patient, maybe we should take out all the lead because you are so young, and think about some upgrade in this particular patient. So you see that he actually had 2 lead, and eventually we extract all the lead for this particular patient, all the old lead. In fact, you can see that there's epicardial lead, which failed after like 6 years, and then end up with a transvenous system. So after that, we take out all the existing lead, and then we upgrade them with a conduction system pacing. Okay, so this is actually after what we did with this particular patient, to using conduction system pacing with the left bundle area pacing for this patient, and this is the ECG after the implantation. And in fact, after the implantation, if you look at the heart function, okay, when comparing to before, you see the heart function is improved. Let me move that. It's not moving, fortunately. But if you look at that, in fact, the heart function looks much better. Okay, so that's why I think in this era, now there's additional option when you actually have patients who have complete heart block, who have left ventricular dysfunction. Maybe conduction system pacing upgrade may be one of the options for those patients. So with that, I just quickly show you a few cases. I mean, with successful lead extraction require careful planning. I think it's very important where you get the access size, what kind of tools you need to use. And also we need to have a clear understanding the type and size of the lead, which is also important whether you're comparing lumen versus luminous lead. And again, important, you may need to selecting appropriate tools. Obviously, the important experience is also important. And again, now in the era of conduction system, it will be a potential important option after knee extraction, particularly in those with left ventricular function impairment. Thank you for your attention.